Hello to everybody. My name is Mojca Matičič. I'm a clinician specialist in infectious diseases and internal medicine, and I'm managing and treating people who inject drugs for viral hepatitis at the University Medical Center in Ljubljana. Besides, I'm also the member of Policy and Public Health Committee at the EASL. This is European Association for the Study of the Liver. It's really a great honor and privilege to present you the EASL guidelines on viral hepatitis elimination with a special focus on elimination of hepatitis C in people who inject drugs. These are my disclosures. So 5 years ago, as you may know, the WHO set up the first ever global health sector strategy to eliminate viral hepatitis as a public health threat, with quite, as you can see here, ambitious interim targets to be reached by the year 2020. And as you can see here, very ambitious final goals to be achieved by the year 2030. But in reality, as presented in the WHO Global Progress Report in May this year, in Europe, the estimates for 2019 show that 300,000 people were newly infected with HCV and 65,000 HCV-related deaths occurred in that year, whereas the number of new HBV infections declined due to the increased vaccination coverage in infancy. But the report also pointed out that globally, and as you can see here compared to HIV, viral hepatitis is one of the first areas to reach the Health Sustainable Development Goal targets by 2020. And actually major increase was achieved in HCV treatment, but huge gaps in diagnosis remain. Because focusing on Europe, only 24% of HCV infected have so far been diagnosed, and the coverage needs to increase because the scale up of diagnostics and treatment has so far been very, very slow. And among 5 strategic directions, the least progress was noted in delivering for equity. What does it mean? It means that the poorest access to HCV testing and treatment services have the most marginalized, vulnerable, and underserved populations that, as you know, actually face the highest rates of infection, such as people who inject drugs. So why focusing on people who inject drugs, and why focusing on hepatitis C to eliminate viral hepatitis? It's quite clear that people who inject drugs in Europe are the driving force of HCV epidemic. They're actually the key population also facing inequities. And as you see here on the right, according to the European Monitoring Center for Drugs and Drug Addiction, the prevalence of hepatitis B virus infection is far beyond the prevalence of hepatitis C virus infection in these high-risk groups. And according to the EMCDDA report, HCV seroprevalence varies dramatically across Europe from below 20% in Czech Republic to up to even 90% in some Baltic countries. So 60% of already infected and 80% of newly HCV infected represent people who inject drugs. 3/4 of infected drug users come from the Eastern European countries. In the last decade, mortality due to untreated HCV infections has been increasing, particularly due to late presentation of HCV by people who inject drugs. And in those over 50 years of age, death from liver disease, including HCV infection, is as equally common as death from overdose. So people who inject drugs are definitely the key population for the elimination of hepatitis C, and the model projections suggest that eliminating the increased risk of HCV transmission among people who inject drugs would prevent a considerable proportion of new hep C infection in this period named here. And as you can see here, the largest proportion may be seen in Eastern as well as Western Europe. Another projection has shown that the WHO Treat All strategy that was launched in 2018 could bring about appreciable prevention benefits. Although, as you can see here, greater benefits per treatment can be achieved through targeting people who inject drugs, which is true for Eastern as well as Western Europe. But you know that the road to achieve these goals, to eliminate hepatitis, turned out to be very, very complex, including several services in a continuum of care, such as you know, awareness and prevention, testing and diagnosis, linkage to care, access to qualified health services, access to medication, and monitoring, as well as evaluation. So a comprehensive strategy to address each step of this healthcare is required, and several modeling as well as real-life studies have shown that to achieve that, a patient-centered care is needed on the individual level. What does that mean? Well, this care is based on four main pillars. Simplification, which means diagnostic and treatment algorithms should be made as a one-stop shop. Then decentralization, meaning that HCV services should be put out of hospitals to regional and local level. Task sharing, meaning that we should involve GPs and nurses to manage complicated HCV cases. And last but not least, integration, which means that HCV testing and treatment should definitely be performed in primary care, at harm reduction services, and as well as other outreach services. But here is the reality. A cascade of HCV care for people who inject drugs really looks very disappointing, since the proportion of drug users being included in the services presents, as you see here, rather a very decreasing cascade, with a very, very small proportion of those who get direct-acting antivirals and who get cured. Of course, there are several barriers and gaps to equity of care for people who inject drugs that actually need to be addressed, and solutions need to be found as soon as possible. Well, and here comes the role of EASL, of the European Association for the Study of the Liver. EASL is definitely the home of hepatology, and within its strategic directions, EASL also set up a framework towards elimination of viral hepatitis, which works in two levels. On a patient level, by launching clinical practice guidelines, and on a public health level, by launching position and policy statement. Well, let's first have a look at the patient level. In September 2020, EASL published the very last or final clinical practice guidelines for optimal HCV treatment. And those guidelines very clearly address also the management of HCV-infected people who inject drugs. And by definition, people who inject drugs include former injectors who've ceased injecting, recurrent as well as current injections on opiate substitution treatment. And among four combinations of direct-acting antivirals, which are approved and recommended in Europe, two of them are pan-genotypic. And so these pan-genotypic treatment regimens actually enable simplification of HCV care, which is particularly important for people who inject drugs. So in pre-treatment assessment, HCV genotyping can actually be omitted if it is not available, not affordable, or if it limits access to simplified treatment. Secondly, fibrosis stage actually has to be assessed initially, but we can use non-invasive methods such as APRI or FIB4 or, of course, FibroScan, which are inexpensive and very reliable. Then, a dose adjustment for methadone and buprenorphine is not needed by using these pan-genotypic genotypes. The treatment with these regimens is simple, short, it's all oral, and it's safe. And finally, and very importantly, a test of cure at week 12 after termination of treatment can be omitted in treatment adherent patients, because the risk of reinfection in drug users has been shown in several studies to be relatively low. So EASL strongly recommends retreatment if reinfection has been identified after gaining sustained virological response. Now, this was an individual level, but from another perspective, on the public health level, it has been documented that broad accessibilities to DAAs can reduce HCV prevalence among drug users, and that a combination of opiate substitution treatment and high coverage of needle and syringe exchange programs can actually reduce HCV incidence by more than 70%. However, the data from the same WHO progress report showed that only 40% of the countries can offer needle and syringe exchange programs, and only 64% of them can offer opioid substitution treatment. And most strikingly, high provision of HCV testing and treatment has so far been realized in only 1% of people who inject drugs. But even the countries that do have a high provision of both services, access to testing and treatment for people who inject drugs still remains, unfortunately, limited in many of those countries for several reasons that are named here, starting with restrictive guidelines, stigma, discrimination, criminalization of drug use, and so on. A recent study that was presented by the European Correlation Network has clearly shown that in Europe, as you can see here, there still exist countries where active drug use or even opioid substitution treatment represent a contraindication for treatment of hepatitis C with direct-acting antivirals. So, EASL tried to overcome this barrier or gap as well. And in 2019, EASL launched a position statement urging all European countries to develop a comprehensive hepatitis C national strategy or action plan, advising country policies to combat stigma and discrimination, to implement harm reduction strategies, to make direct active antivirals available and accessible, and of course, to improve access to treatment and care, especially for those who are at high risk, and of course, to provide also rapid testing. Indeed, EASL made also a step forward in recommendations for a drug use policy in the context with the global hepatitis C elimination goal, because drug policy in Europe is a direct barrier to achieving the goal of HCV elimination, because most of European countries have laws that criminalize the possession and distribution of drugs. So, in its policy statement from August last year, EASL strongly recommends that all barriers to the uptake of healthcare services by people who inject drugs be removed by changing policies and discrimination that hinder access. And this also includes the decriminalization of minor non-violent drug offenses and the adoption of an approach which is based on public health promotion, respect for human rights, and evidence. But to eliminate HCV drug users, combining activities is required, which means that decriminalization of personal drug consumption and possession needs to be integrated with interventions such as HCV testing, treatment, and counseling, because only in that way, people who inject drugs can freely access centers of assistance and get the continuum of care as needed. Well, we cannot avoid COVID-19, of course, because during the last year, the COVID-19 pandemic has strongly impeded the delivery of core services, as it was shown with several studies, and particularly testing for HCV, and particularly within the community, which mostly affects people who inject drugs. Together with European Society for Clinical Microbiology and Infectious Diseases, ESCMID, EASL immediately launched a position paper in April last year and its update in August last year. So updates on care for patients with liver diseases during COVID-19 pandemic, with a special emphasis on maintaining activities towards viral hepatitis elimination by using new approaches and new technologies. And to avoid the COVID-19 impact in the future, here, as you can see, is another public health intervention of EASL, vaccination against COVID-19, which is strongly recommended by EASL for viral hepatitis patients, as well as for the population as a whole. So to conclude, ladies and gentlemen, as recommended by the European Association for the Study of the Liver, the cornerstones to get on track to eliminate HCV in people who inject drugs are patient-centered services, simplification of care, and avoiding stigma, discrimination, and criminalization of personal drug use. Last but not least, allow me to kindly invite you to upcoming Hepatitis Elimination Conference 2022, which will be organized by EASL, held in Brussels, hopefully on spot, in February 2022, where all the dilemmas and unsolved issues towards elimination of viral hepatitis are going to be discussed, and you're more than welcome to attend. Thank you very much for your attention.